Hello, everyone. I'm Dr. Shalini Mishra, and today I'll be talking to you about the use of hyperbaric oxygen therapy in oncology practice. In the beginning, I would like to thank the organizers and especially Dr. Ravi for giving me this opportunity. So, what exactly is hyperbaric oxygen therapy? Let's just start with that. And basically, it is a kind of a medical treatment that facilitates the body's natural healing process by inhalation of 100% oxygen and in a total body chamber where the atmospheric pressure is increased by a factor of 2 to 3. So normally we increase the atmospheric pressure to double atmospheric pressure, and we go up to safely up to 2.4 atmospheric pressure is what we get. So it's important to understand that it's just actually just facilitating the natural healing process, and it's not creating any magic as such. This is how a typical treatment table looks like, and thanks to the Techna for sharing the slide with me. So this is how where we start at 1 atmospheric pressure in the beginning, and there is a slow descent for about 10 to 15 minutes. And this is followed by, once you achieve the pressure that you want to give, that is double atmospheric pressure, which is equivalent to about 33 feet below the sea level. And the duration can be fixed depending on the time. Usually it's anywhere between 60 to 120 minutes. And then again, there is a slow ascent back to 1 atmospheric pressure. There are mainly two types of chambers. One is a multi-place chamber where more than one person can be there, more than one patient can be there, and even a nurse or a technician can also be there. So the whole chamber is pressurized, but the oxygen is 100% oxygen is delivered through masks. And then we have the monoplace chamber, which is the one that we have at our institute, at Rajiv Gandhi Cancer Institute. Here, only one person can go in at a time. And the whole chamber is pressurized, as well as the whole chamber has 100% oxygen. So the effectiveness of both are equal, and there's been shown that there is no difference in the effectiveness of either modality. So it's just a matter of availability and comfort. A very brief overview of hyperbaric oxygen therapy. The role is well established in burns and wound healing, and of course in radiation injury. That's what I'm here to talk about. We've already heard some very good talks in the morning today, and its role in oncology practice is definitely increasing, and especially for late complications of radiotherapy. The objective of today's talk is basically to highlight how HBOT mitigates the treatment-related toxicities of radiation without interfering with the oncological control. A brief look into the pathophysiology, what exactly it does. So in the normal circumstances, the oxygen is transported throughout the body only through red blood cells. So when we give hyperbaric oxygen therapy, the oxygen, because of Boyle's law, the oxygen not only dissolves, not only is there in the RBCs, it saturates the RBCs. In addition, it dissolves in all of the body's fluids, including plasma, lymph, and CSF. And hence, even to those places where the RBCs are not able to go because of the blood vessels which have been fibrosed, so the oxygen actually reaches there through the body fluids, and even despite having blocked vessels. And that is the advantage of hyperbaric oxygen therapy. And so this increased oxygen not only improves the oxygen supply to the tissues, it also enhances the ability of the WBCs to kill bacteria. So it has a synergistic effect with many of the antimicrobials as well. So often we have, multi-drug resistant infections and non-healing wounds, and that is where HBOT really, really helps in treating these patients. But we must remember that this oxygen cannot be absorbed transdermally. So it has to be completely through the pulmonary system. And so it is inhaled because there are some people who do talk about some oxygen chambers which are just placed around the diabetic foot. That is not in the true sense hyperbaric oxygen therapy. So just let's look at what exactly happens in radiation injury. So we all know that radiation is a very useful adjunct for cancer treatment, and because of its ability to interfere with the DNA synthesis, and it stops these rapidly dividing cancer cells from completing their mitosis. But in effect, what happens it controls the cancer, but there is some effect on the healthy surrounding tissues as well. And what exactly happens is obliterative endarteritis. So it causes edema, it causes fibrosis, it decreases the blood supply to all the irradiated areas. So very commonly we see this in a patient who has had radiation for CA cervix or CA prostate, and they have these side effects of radiation on the adjoining organs, which is radiation cystitis in the bladder and radiation proctitis in the rectum. So because of obliterative endarteritis, there is tissue necrosis, and this is what causes all the damage of late radiation injury. And this diagram is just explaining the same thing about the acute phase, the latent phase, and the late phase, which can happen after years. So I've seen patients having radiation cystitis after 10 years, after 12 years of receiving radiation. So there is no limit as to when it can happen. It can happen at any time. And here we can see in the chronic phase or late phase, there is a lot of collagen deposition, there is fibroblast infiltration and arthritis, and that is what causes most of the symptoms. So how exactly does HBOT mitigate this radiation injury? So we have seen that radiation is causing hypoxia, fibrosis, microvascular injury, and here comes hyperbaric oxygen therapy. It not only increases the oxygen tissue tension, it also induces angiogenesis, it causes fibroblast proliferation. So it's just the opposite of all the things that radiation was doing, and that's how it is able to reverse the radiation injury. So it stimulates collagen synthesis, and even stem cell mobilization has been shown. It definitely decreases the edema and inflammation. So because of that, usually these patients will be having a lot of pain because of the cystitis or proctitis, and pain is the first symptom to go. That is what my observation is. And the decrease in edema inflammation is because of the vasoconstriction that is caused by the hyperbaric oxygen therapy. And at the same time, it has been shown that it does not actually promote tumor recurrence or growth. There are different opinions on this, and different studies say differently. So, being a beginner in this field, I am a little cautious, and so are our clinicians. So, if there is any active disease at anywhere in the body, then we usually try to avoid HBOT unless it is a life-saving thing. For example, a very bad radiation cystitis where the patient is really bleeding very badly. So, what are the common in radiation-induced complications where HBOT helps? And I think the one of the most commonest thing that we see is osteoretinal necrosis of the mandible, and it has been shown to have good success rates in the early stages, almost equal to 70%, with the combination of surgery, which is the debridement of the sequestrum or the dead bone, along with HBOT. So, usually give a sandwich therapy. We give 15 to 20 drives of HBOT followed by surgery or the debridement, and again we cover it with another 15 to 20 dives of HBOT. The second commonest thing that we see is radiation cystitis. So definitely it is very effective in radiation cystitis. It decreases the hematuria. Usually the patients will be really quite miserable with all the bleeding and all the lower urinary tract symptoms, the dysuria and pain, and even the frequency. So most of our patients have seen that, they are not able to even hold urine for about 5 minutes, and they go in diapers into the HBOT chamber. And at the end of the 15 or 20 dives, I've seen that most of them can actually hold their urine easily for about 1 to 2 hours. Of course, it depends on each patient. And so overall success rates from different reports quote around 65 to 90% of success rates, which is a very good success rate, I think. Radiation proctitis. Now, this is a little bit more difficult to treat in the sense that it requires more number of sittings. And even these patients, when they improve, they are really so relieved from these symptoms. So some of my patients, they both radiation cystitis and radiation proctitis, they're quite miserable. And they often come and say, why didn't somebody tell me when we were getting the radiation that, we will land up here in this terrible situation? They have a lot of, they've gone through surgery, chemo, radiation, but they find this the most debilitating. And also, at the end of their treatment. So many of them are financially drained and they're quite depressed as well. So they need a lot of counseling and reassurance because HBOT doesn't work like magic that you take two sessions and then you're cured of your problem. It takes time. It's a slow healing, slow recovery, and actually because it's promoting the body's own healing mechanism. Then, of course, we have radiation skin injuries, non-healing ulcers, just like similar to diabetic ulcers. So, ulcers and in the area of radiation field, radiation ulcers. And of course, the most gratifying results that we've had is with flap necrosis in previously irradiated fields. So, we have a very busy head and neck reconstructive oncology department. They do, our plastic surgeons, they do anywhere between 3 to 5 free flaps per day, 6 days a week. So we do see a lot of patients who are undergoing these surgeries after previous radiation, and that is where HBOT helps in those patients who have flap necrosis. I'll share a few case studies a little later on. There are some certain other radiation complications as well for which HBOT has been found to be helpful, like soft tissue radionecrosis in the pelvis or head and neck. So here I would like to say that we've seen a few cases of brain necrosis post-radiation, and they have really, really done very well with HBOT. So just 7, 8 sessions of HBOT, and they get up and they start walking, and their pain goes away, their hemiparesis improves, and their headache improves, their gait improves. So it's been very gratifying to do this for radiation-induced brain necrosis. It's also been described for laryngeal chondronecrosis. I'm yet to see one, chest wall radionecrosis, and some limited evidence on brachial plexopathy. A lot of studies have shown that HBOT is very effective for late radiation tissue injury, and the UHMS approved indications are, of course, for radiation tissue injury for both soft tissue and bone, as well as for flap necrosis and skin grafts. The limitations are that these studies are small trials, and we need more randomized controlled trials. And also, there is a problem with the accessibility of HBOT therapy as well as the cost issues. So I'm going to share my journey as in charge of the HBOT at Rajiv Gandhi Cancer Institute. So it's been exactly just about 3 years as I'm recording this talk today since we set up the monoplace chamber in our institute. And this is my team. So our workload is not huge, but we are happy to be growing gradually. And so totally we have done about 1,900 dives in exactly 99 patients. So these 99 patients, they do not we don't add the patients. If they come back to us again, we count them as one. So there are many patients who had taken 10, 20 dives, improved, and they maybe after about 6 months or 1 year, they required another 20 sessions or 40 sessions. So we include them as one patient. So it's exactly the number of patients we have touched through the HBOT, and it's been about 3 years, as I already mentioned. So these are some of the indications that we see commonly. As you can see, the most common is osteoradionecrosis of the mandible, as well as radiation cystitis, and that is followed by flap necrosis, non-healing wounds in the radiation field, radiation proctitis, orocutaneous fistulas after radiation. We've seen a few of those, radiation-induced brain necrosis, I already mentioned. And we've also seen a couple of patients who had biphosphonate-induced osteoradionecrosis, and they did have some improvement with the HBOT, though it wasn't as good as the ORN. So coming to radiation-induced hemorrhagic cystitis, it can be very, very perplexing. As I mentioned earlier, the patients keep losing blood. They require repeated cystofulguration, and they are quite miserable with their symptoms. They have a catheter. They are undergoing bladder irrigation. So, and this is how a typical cystoscopic picture looks like for radiation-induced cystitis. And how exactly the HBOT helps. First of all, it's a non-invasive treatment, but definitely it has a lot of improvement. And the first thing that happens is relief in the symptoms. As I mentioned earlier, the pain decreases and their hematuria decreases, and most of them by about 10th dive, their catheters have been removed, and they're able to be discharged, and they go home. And definitely, it stops the progression of this hemorrhagic cystitis. It stimulates angiogenesis, and that reestablishes the blood flow to these affected areas. And that's how it heals all those radiation ulcers inside the bladder. It also helps in maintaining the bladder functionality. So the duration that they are able to hold their urine also increases, definitely. And a lot of studies have shown about 75% patients show a complete response to HBOT alone. Of course, we do add on the drugs, and we always do the HBOT after the cystofulgration. So this article from 2023 shows a schema of how hemorrhagic radiation cystitis should be treated. And you can see here that soon after the cystoscopy and the cystofulgration, the next step is HBOT. And so the other modalities like intravesical alum and formalin, which are also quite, they have long-lasting effects. When we didn't have HBOT, we did do this for a couple of patients, and they have terrible bladders now as they've grown. And of course, if nothing works, then you do a surgical diversion or a definitive cystectomy. So at RGCI, this is what we do if there is no active disease. That means, suppose at the time of cystofulgration, if they've taken a biopsy and that shows active disease, then we avoid giving HBOT, because that explains that probably the bleeding was because of the tumor which was present. And also the clinicians are a little bit wary about giving HBOT in active tumor disease, because some studies have shown that it may cause dissemination, although it has not been proven. And there are a lot of studies which give HBOT, as synergistic along with chemotherapy, and also soon after radiation to mitigate the radiation side effects. Especially if you're giving re-irradiation, you could actually do it prophylactically, even without the patient having any problems. So we do get a referral straight away from the recovery rooms as soon as the patient is done with the cystofulgration, or from the ICU if they are there as the post-operative area. And if patient is stable, then hemodynamically stable, we just start it the next day itself. And I'm happy to share that we've done it for about 25 patients, and only 3 of them had to undergo cystectomy. So we've had a very good complete response with HBOT alone. Some success stories about flap necrosis. This 54-year-old man with buccal mucosa malignancy, and he had undergone surgery as well as radiation earlier. And then the mandibular plate got exposed after about 9 months, and he underwent a surgery for removal of that mandibular plate. Excuse me. And after that, the flap necrosed, as you can see here in these pictures. And serially, they debrided. And after about 25 days of trying everything, they referred the patient to me for HBOT. And you can see how bad towards the right of the wound, you can see how bad the wound was, despite the regular dressings and irrigations and everything else that they tried. So after giving about 20 dives of HBOT, you can see good, healthy granulation tissue. And then finally, the patient underwent a redo flap surgery and is doing quite well. Everything is healed. You can see the skin, the neighboring skin also. It shows a huge difference. Some part of it has been removed probably in the next surgery, but you can look at the neck skin and the cheek and all the surrounding skin. And he totally took about 48 sessions. He had a very difficult phase, but he managed it and he pulled through. He's doing well. Another 49-year-old patient with multiple, recurrences in the oral cavity, and he underwent a huge surgery with maxillectomy, mandibulectomy, and everything. And they put a flap, and it necrosed. So they took him up for re-exploration. They put another flap, and it necrosed. So after about 32 days of trying all this, this is the situation when this patient was referred to me. Of course, he had a tracheostomy. If you can see very closely in the right-hand side picture, you can actually see the Ryle's tube. So he also had a pharyngeal fistula. And we started him on HBOT and nothing else, just supportive care and HBOT. You can still see the Ryle's tube on the left-hand side picture, top left corner of the wound. And gradually, everything healed after just about 20 dives. I think this is really remarkable. And he's also doing well, and he's luckily disease-free as well. And even the pharyngeal fistula has healed. Another lady, 52-year-old, she was diabetic on top and she had a leiomyosarcoma of the back. She'd undergone surgery and radiation. And then she had developed a radiation ulcer. So they did some rotation advancement flap and that necrose. So almost after 50 days of trying everything, she was miserable. She was undergoing regular dressings with a lot of debridements, and she was having fever. She was requiring a lot of high, strong antibiotics, very expensive. She was admitted in the hospital for these 50 days. And that's when they referred to me, and we started her on HBOT, and you can see what a remarkable change in the wound. Just about 17 dives. Unluckily, we lost her to disease progression because she already had lung mets, and but her wound was so much more better. Her antibiotics were stopped, and she was able to go home. Another 64-year-old man with multiple primaries in the head and neck region and previous flap and another flap. And you can see the free fibula flap has necrosed so badly. You can actually see the entire free fibula, which has been grafted there. Previously, the whole flap has come off. And this again happened after a plate removal. So any dental procedure, plate removal in previously irradiated patients, those are the usual triggers for flap necrosis. So this man was referred early because of our previous experiences, good experiences by the plastic surgery team. And subsequently, after 20 dives, he underwent a redo rotation flaps. And we actually again bridged him. We gave some 11 dives and did the surgery, and again gave another 9 dives. And actually, he's actually reading a newspaper in the left side picture. Although appearance is not that appealing, but at least he was able to go home and he had a functional chin. Another lady around 47 years old, again buccal mucosa. Soon after, she had very bad radiation skin burns. You can see it in the top left picture, and she had developed a orocutaneous fistula. So she was started early by the radiation oncologist. She was referred for HBOT very early, in fact, 48 hours after the radiation was over. And in 5 or 6 dives, you can see her skin, the radiation burns have healed so beautifully in the lower left corner. That's just about after 6 dives. And after this, the fistula was still persisting, so we gave her complete. I think she took only about 11 dives because she had some middle ear complications. She had otitis media, so she discontinued. But just with those 11 dives of HBOT, you can see in these follow-up pictures that the fistula has completely healed and her skin is almost normal. It's just like the other side. There are no changes. Another 74-year-old lady with recurrent CA tongue. You can see the reconstructed tongue over there. And she had OR in both mandibles after a gap of almost 12 years. Quite miserable. The lady couldn't eat anything. She had so much pain and she had foul smell from the mouth. You can see those ulcers in the top left picture. And so again, we gave her the sandwich therapy. We gave 15 dives of HBOT followed by sequestrectomy, and then another 15 dives, and everything healed beautifully even at that age. And she was so happy. So I'm happy to share these success stories, and I'm sure that all of you will be encouraged to use more and more HBOT in these complications. So I would just like to, before I end, I would just like to mention some limitations in the use of HBOT. The first and foremost is the cost and the availability of chambers, but I'm very happy to see that there are a lot of Indian companies who are making these chambers available very easily in various parts of the country and at a very affordable cost. And really thankful for that. Again, we need more larger RCTs to strengthen the evidence and to promote HBOT further. One more disadvantage, of course, is that the duration is so much more longer. It takes almost 2 hours for each patient, each setting. And then you need to take it for at least 20 dives, sometimes 30, sometimes 40, sometimes even 60. So they need to be so motivated to keep coming, especially if they are staying far away from the place where they are taking the HBOT therapy. In future directions, definitely we need to expand the role in survivorship care and potential integration with regenerative therapies as we are here today, like stem cells and PRP, etc. And of course, improving the accessibility and cost effectiveness, improving the quality of life in cancer survivors. And definitely this is a field which is going to expand in future oncology supportive care. Thank you so much.